871 in medic 6. You're seeing a 74-year-old male, shortness of breath.
Multi-vehicle collisions, natural disasters, industrial accidents, or fires. Most MCI experience comes from these events. Blast injuries can be caused by a variety of events, not just terrorism. Even grain silos can be a source of explosions. Unfortunately, these threats are very real today. Are you ready? Planning goes a long way toward readiness. Has your agency identified possible targets within your community? Focus should not only be on government buildings or high-profile organizations, but also needs to include large public assembly areas like sports arenas, colleges, mass transit sites, and agricultural areas. Some events may be smaller in scale, such as responding to clandestine drug labs or booby-trapped storage or growing areas. When responding to any incident at one of these places, approach with a high index of suspicion and with safety in mind.
You'll first want to think through what is the potential that this is a terrorism incident versus a naturally occurring incident. Some of us work in areas where there are natural places where those occur. Those may be in mines, those may be near refineries, those may be in places where we know all the buildings are natural gas powered. In those circumstances, we may expect that terrorism or another man-made event intended to hurt people have not occurred, in which case scene safety involves simply knowing that there was something around that caused this to begin with, and let's take the precautions to make sure that a secondary explosion does not occur. Some circumstances, though, will be very suspicious. They've occurred in a park in association with a big event. They've occurred in a stadium. They've occurred in the city near a big governmental building, in which case our safety response will be one that dedicates us to preserving evidence for law enforcement and to making sure no secondary targets, particularly target-rich areas like casualty collection points. We will have to change our safety priorities there, allow law enforcement to build perimeters for us, make sure that there's no other physical objects like trash cans, plants, and other things where bombers will typically plant secondary explosives in an attempt to hurt the rescuers. Scene safety will be a prime consideration for those two areas. One being a potential natural secondary explosion. Second is if there is another device that is present or multiple devices that may injure the rescuers.
You can best prepare for any type of event that can precipitate a blast by responding to day-to-day events with a consistent, organized approach every time. Drills should include multi-jurisdictional response. This includes fire, law enforcement, EMS, and other public entities. Everyone should be familiar with the action plan in response to an event at identified locations. This will create the foundation and automatic responses necessary if an event occurs.
We work through our various partners. We establish the building blocks on a day-to-day basis, and then do some special pre-plan around what others have helped us learn about terrorist events that will help us deliver the greatest amount of care to the greatest number of people in the shortest period of time.
Unified command and staging areas should be established early. Your safety is paramount. Never enter a scene until cleared to do so. Follow the directives from the incident commander. Emergency vehicles should be out of the suspect's line of sight. Responders should be prepared to evacuate or to relocate sectors at a moment's notice. Only trained tactical medics should be deployed into the hazardous area to assist in triage and extractions.
Can you hear me? Can you see me?
Suicide bombings have the potential to produce a large number of victims and fatalities. How the patients are handled and scene is controlled is critical to your safety and success.
The terrorism environment clearly tells us to be worried about the impact of secondary devices. Then we need to move patients quickly away from the scene, need to have the hospital set up so that we relocate the disaster to the hospital, ask the hospital to secure its borders. In the Israeli approach, every ambulance that gets approached gets inspected to make sure that the ambulance isn't a secondary device that is intended to go off when it gets inside and close to the hospital.
Bombing events can present unique triage, diagnostic, and management challenges. Care should be delivered in a secure location away from hazards. You may need to consider removing injured victims from the area before triaging or delivering treatment. Consult your local protocols regarding triage. Depending on the circumstances, this inverted triage process may do the most good for the highest number of patients.
Inverted triage occurs when the rescuers encounter and deal with first those that are less injured. Typically, as we move into a multiple casualty event, we move towards the area where we know that there are the worst injured victims. A very common multiple casualty incident for our rescuers is motor vehicle trauma, and we typically kind of blow by the people who have the lesser injuries who are standing around at the scene to get to those that may still be trapped and may be worst injured. The law enforcement, military, and Israeli experts in dealing with this say inverting that and dealing with the less injured, getting them off the scene so that there's no collection of casualties, no target-rich environment for people to come in, shoot it up, or to set off a secondary device is the right way to move these incidents and to save the most lives. And therefore that inverted triage of dealing with the less injured first and moving towards the most injured is better overall for the victims.
Very few civilian medics have experienced treating blast-related injuries. Explosions produce unique patterns of injury that are seldom seen outside of combat. When they do occur, they have the potential to inflict multi-system, life-threatening injuries on a large number of people simultaneously. Injury patterns result from a combination of the amount and type of materials, the surrounding environment, the delivery method, and the distance between the victims and the blast. Understanding the physics of an explosion and how energy is released can help you anticipate injuries or aid in your treatment decisions.
Blast waves occur when the heat and the pressure gradients occur from the interaction of the chemicals. That blast wave is a force that can be moving up to 1,500 miles an hour, and at 1,500 miles an hour impacts the body, again affecting most the hollow structures, the air-filled structures, and then the overall substance. As well, in that blast wave come objects that may be moving towards the victim at a very high rate of speed. That blast wave can move them, so pick them up and throw them up against something or throw them out of a structure.
Blast injuries are categorized into 4 types: primary, secondary, tertiary, and quaternary, or miscellaneous.
The main cause of death is a fatal injury, first of all, to the lungs, as the largest air-filled space in the body, and the one that has to do the biggest job of trying to absorb the blast wave and the pressure differentials. The lungs will lose their integrity, fill with fluid very quickly. That's called a blast lung. When the patient is not breathing when you arrive, they've likely incurred a fatal injury, and in most bombing circumstances, those victims are written off immediately. So the immediate blast wave impact on the lung causes a blast lung, may in addition cause bubbles of air to be flowing through the body, air emboli, which cause effects in the brain, effects in the heart. And so after the primary injury to the lung would be injuries to the brain and to the heart, which would result in the death of the victim.
Signs and symptoms of primary blast injuries, or PBI, will range from obvious life-threatening to very subtle. Any body system may sustain injury, including the central nervous system or cardiovascular system. Primary blast injuries may be overlooked when secondary injuries are more apparent. Secondary blast injuries result in penetrating trauma from flying debris and bomb fragments. Bomb makers often incorporate additional projectiles into their explosive devices to increase the lethal effects of secondary injuries. Again, any body system may be affected.
Shrapnel wounds are a secondary pattern. Some bombs and some bombers have come to use shrapnel as part of the way to spread the terrorism event. Eric Rudolph in Atlanta liked to pack his bombs with nails and other pieces of metal shrapnel. Now that expands the injury zone out to at least 100 meters away from the primary kill zone, which may only be 5 to 10 meters, depending on the explosives. But the addition of shrapnel, or the natural shrapnel that occurs, the most dangerous and common of which is glass, that if the blast wave sends those objects out towards the victim, they can result in the penetrating wounds. Some of those are not real obvious to begin with. The rescuers will have to look very closely to see whether these are just pepper wounds or whether in fact shrapnel has penetrated into the body.
Tertiary blast injuries occur when the body is propelled by the blast wave into walls or scene debris. This results in additional blunt or penetrating trauma, fractures, amputations, and brain injuries. Quaternary injuries from bomb blasts include the inhalation of dust, smoke, carbon monoxide, and other chemicals, an exacerbation of pre-existing medical conditions, thermal burns from gases or secondary fires, and crush injuries resulting from entrapment under collapsed structures. 10% of all blast survivors have significant eye injuries.
Once we have made it past the evaluation of the hollow structures and understand that the hollow structures tell us that there may potentially be more serious injury beyond, then we get to assessing circulation. Circulation is perfusion, and we need to assess all of those things that together allow us to know how well this victim is sending oxygen out to the brain and to other important organs and able to return it. That's mental status, that's skin condition and color, that's the body's ability to maintain a pulse and a blood pressure, that's the availability of a pulse oximetry pulsation that will allow us to get a reading.
Patient history should include information about the patient location at the time of the blast. Patients that were in a confined space near a wall or close to the blast will suffer greater injury due to the limited ability to dissipate energy. A blast wave is magnified when it comes in contact with a solid surface.
Individual victim care then ensues when EMS providers can then focus on the individual victims. We typically use, again, the ABC that we're taught, we remember, and even in our sleep, we know to assess the airway, assess breathing, assess circulation, assess disability, and expose for other potential wounds. In our blast victims, we're looking for injuries, again, to hollow structures. The lungs, what shape are they in? How is this victim able to breathe? If they have received shrapnel wounds, or other damage to their face, what potential or real compromise is there to the airway? What is their shock status? How are they perfusing? And above and beyond what they obviously we can see, we want to assess whether that victim has received internal injuries. So we anticipate that they will have a blast effect to their eyes, may not be able to see well. We anticipate that there will be damage to their ears, and they may not hear us as well. We may have to work more on talking loudly to the victims, making sure that they can read our lips, because they won't be hearing as clearly as they would have otherwise. So anticipating injuries to ears and to lungs, we hone in on those very early on in our assessment.
Your ability to identify and manage penetrating and blunt trauma, or burns, will help you to manage patients suffering from a primary blast injury.
Breathing, providing an oxygen-enriched environment, will allow the patient to deliver as much as possible to the heart and to the brains and to other important organs. So applying 100% oxygen is critically important. If the blast has occurred, some smoke, some dust has irritated the airways, those people may not like dry oxygen, in which case humidifying it by putting some saline in the nebulizer will help those patients be able to tolerate the extra oxygen that they need, and that oxygen then can help them in perfusion. Circulation, we close off any open wounds to make sure no air gets into the wounds and goes to places where it doesn't need to be. So closing up any of those open wounds, we would particularly be concerned about ones to the neck, the face, and to the chest. close up those wounds to seal them off, control any external bleeding that we can see, immobilizing any impaled objects, and with blast injuries will come impalements. We don't want those objects to be removed, stabilize them in place. Disability, that is taking care of the spine, the spinal cord, and the nerves. Careful immobilization, making sure that the position that we put the patient in doesn't cause them further compromise. Many of those patients feel better after an injury to the lungs in a sitting up position. They will be able to move their lungs and their chest wall the best. They will then require us to immobilize if we're concerned about them in an upright position.
Powerful explosions can cause a variety of injuries. The most obvious will be external injuries from blunt and penetrating trauma. But don't forget, primary blast injuries can cause internal injuries that are not easily seen or readily apparent. Have a high index of suspicion as you assess for internal injuries. Prepare to treat hypotension caused by serious blood loss, air embolism, tension pneumothorax, or vagal reflexes.
Hypotension is a very ominous indicator in the blast patient. That patient typically has had very severe damage to their lungs or their heart, or has lost blood from penetrating injuries or something else to the point where their perfusion is compromised. Shock is ominous and typically means that the victim is dead. So if we are going to treat it, we have to treat it very aggressively, anticipating that there are major injuries to the lungs and the heart, or such blood loss has occurred to cause it. And so we need to move very quickly to oxygenate, expand volume, and treat any primary injuries that we're aware of. There's one additional potential cause for shock in these patients, and that is air emboli. Air emboli occur when there's been damage to the lungs in such a way that bubbles of air are now passing through the heart, passing through the brain, maybe compromising so much flow that the victim presents in shock. In order to treat this, we have to be able to allow no further air bubbles to occur, and what air bubbles there are have to be oxygen enriched. So we close up any primary wounds that we can find and then put 100% oxygen on the victims in an attempt to get them to clear those bubbles most quickly.
When an explosion occurs in an open space, patients may complain of tightness or pain in the chest. They may cough up blood or have tachypnea or respiratory distress. If they complain of any ear problems, suspect serious injury to the lungs.
Treatment priorities will again focus on the ABCs. As with other trauma circumstances, we need to capture an airway, and if there's potential damage to it or potential loss of it, we will need to make sure that we have an airway device that is in place that will allow the victim to survive to the hospital. In some patients that can't keep their own airway, they have so much swelling, they have so much bleeding, they have so many secretions that we need to do an early airway intervention. That early intervention would be an endotracheal tube, either placed through the nose or usually through the mouth. And occasionally from the blast wound we can't access from above, and we will need to do a cricothyroidotomy, either with a needle or with a scalpel. Those patients have devastating injuries. If that airway is that compromised, we will need to make a very early intervention in order to save their lives.
A pneumothorax is a common injury, and if it progresses to a tension pneumothorax, it indicates emergency decompression in the field. Avoid delivering oxygen under positive pressure. This can increase lung damage. Intravenous fluids may also be poorly tolerated and could potentially cause pulmonary edema. After life threats are addressed, don't forget the psychological needs of your patient. Due to hearing loss or eye injuries, your patient may need reassurance through touch and empathy. If possible, having family members in close proximity can provide additional support. Not only will the psychological scars remain with these victims, but long-term health effects may be seen, days or even years later. Some of these effects include hearing loss, headaches, memory disorders, and post-concussive brain disorders.
Part of the pattern that they're seeing is a concussion syndrome. From the blast wave, the brain is enclosed in a fluid space. The brain is forced to one side and then the other, so you have a coup contre-coup injury pattern, which can result with frontal injury in the cognitive changes. With posterior injury, it results in kind of classic concussion syndrome, blurring of vision, hearing with ringing in the ears and echoing. There's problems with long-term and short-term concentration, long and short-term memory, and people have continuous headaches. Those are fairly common presentations of a post-concussion syndrome, and we may in the civilian world see that in blast victims days to months down the line when those people still feel impairment related to the primary injury.
While bombings will probably not happen in your area, the possibility of an explosion in an industrial environment, a mine, or clandestine lab is possible. Having a good understanding of the effects of bomb blasts and the various mechanisms of injury associated with these types of events will help you deliver the most appropriate care.
In an event that's potentially or is really a terrorist event, we need to move people away from the scene most quickly so that we don't leave target-rich environments at the scene. Others would tell us that scoop and run philosophy and moving patients off the scene most quickly will allow us to save the greatest number of people and not present secondary targets. Finally, the individual care of the victim needs to focus on those things that most likely are injured, and if they are injured, we anticipate further injuries amongst the victims. Look for injury to the eyes, look for injury to the ears, look for injury to the lungs, look for injury to the intestines, look for shrapnel or impalement injuries that come along with blast and burn, and treat those aggressively.